I'm here, we're gonna have a conversation with Dr. Shaun Garcia about, he was with me when we did the process one day, part of the process.
Uh-huh.
So I just wanted to run through a little bit of that and then just have a little bit of Q&A back about, working in the ER and different ways, different things you saw and different ideas I have on how to approach that. So in a global sense, from a provider standpoint, what we're doing with the process is just moving the dock box area to the front. And so I know you weren't there for a ton of time, but what did you kind of see when you were up there of how it worked?
So the day that I was here, we transitioned the providers out into the triage area. It seemed like we were working a little closer with nursing staff that day, working together to see the patient for the first time, which I think the patients appreciated because they're walking in and getting evaluated immediately as they're getting brought back. I conducted a few patient encounters that morning with the new process in place where the provider was sitting up and greeting the patient right at triage.
And what did you think? What did you think of the process? Because it's a shift from what you've done before.
So the couple of cases that I did were appropriate in that setting.
Uh-huh.
It seemed like they weren't high acuity coming off the ambulance and things like that. So that part worked well.
Well, let's hit on that part, right? Because that's a great point. Great point. So I love talking about patient types. So one is EMS coming in through the back door, which is one group. I'm going to push that off to the side because we wouldn't see that in the triage.
Right.
But let's say that you had somebody with sepsis, septic shock that comes through the front door, or a STEMI. Do you think that process would work with that, or what do you think the problems with that kind of approach would be?
I think that the communication with the nurse leader at that time is kind of most important, in terms of realizing and recognizing that this patient is going to be an acute care patient and it's going to warrant kind of immediate medical care, and then we need to get them back to a room and start the process a little faster than maybe somebody that you're going to see in triage and maybe even treat right then and have them leave from that area and be discharged.
Yeah, one of the interesting things, and having rolled this out at different places, is different people have different opinions of what happens out front.
Right.
But it really is simple. We all do the same thing.
Right.
The difference with this process is you contact the patient sooner.
Mm-hmm.
So a lot of the skill of a practitioner is recognizing what's going on, and we're not necessarily algorithmic like that. So you look at somebody and you say, well, they look like crap. There's probably something bad going on, and then you can initiate and push things downstream much quicker. And then the communication with the nurse is a big part because they know what your next steps are in doing things.
Right.
So it's interesting, in the one place that I ran this and we tracked out the data, it took our septic shock mortality rate. Now this includes EMS coming in the back, so it's all septic shock, but a lot of it came through the front because 80% of our patients come through the front.
Right.
And it took the mortality from approximately, 20% down to 2%. And it wasn't that the providers did anything different, we just recognized it earlier.
Yeah.
So it's interesting to see that perspective because there's, I break patients into three groups. The ones that you're going to discharge pretty immediately.
Right.
The ones that are going to be admitted, and then the sick people. And really the sick people is what we're there for.
Right.
But it's our eyes on that pick that up. What did you think of the process and when you did it? Did you like it? Not like it? Is it like a unfitting shoe that you got to get used to?
I think probably the latter. It's not something that I've been exposed to before. Other than when I worked in urgent care, that was pretty fast. Like I saw the patient, they were only out there getting vitals, and then I saw the patient.
Yeah.
But in the more traditional inpatient setting in the ER, there are typically a few steps between when the patient gets triaged and when the provider actually sees them.
Sure.
So in that sense, I liked it because the patient comes in and I can see that, okay, this is not going to be an acute care patient. This is a patient that I can probably see right now, get the history, and decide on a treatment plan. They can discharge from there.
Yeah. It definitely facilitates the treat and treat.
Right.
And then, when I broke it down into the high acuity patients, we're at the bedside, right? They go wherever they got to go and the resources are localized. But all those other patients, we all kind of do the same thing, right? We just order a bunch of stuff, and some of those we know are going to be admissions, and some of those might be admissions, but we really don't care. We just got to order a bunch of stuff and then get our results and then figure it out from there. So it really, what it does is it creates a push system. Whereas in the past, the system you're talking about with the steps before they get to the bedside was you were pulling the patient back. And then you were pulling the provider in there. But in this way, it makes people a little bit uncomfortable at first. So you're kind of pushing it because the patient's pushed on you. Right. And then you make decisions and you push it onto the nurse. And then the nurse does stuff and then pushes it back onto you of what are you going to do with the patient. Right. So, there's definitely a shift. What do you see as hurdles with it? Do you see any major hurdles from a provider standpoint? Other than it's different.
Well, so for our patient population, specifically here in Springdale, some of the patients have kind of poor health literacy and maybe are not fully understanding their actual past medical history. So if you're just having that brief encounter with them and you're thinking, okay, this person came in for nausea, vomiting, diarrhea for a week or two, and you kind of go through your gastritis protocol, and they look okay, but then the labs come back and the white blood cell count's 30,000. So I had a patient like that, and come to find out she was in renal failure. She had an ejection fraction of 15%. But when I admitted her in the ER, initially when I saw her, she looked okay to me. So that's the only thing where I go, okay, if the provider is just seeing that patient, on the first time initial reaction, and you're kind of trying to decide, I'm not going to treat and treat this person or admit them, or where are they going to fall? Right. Sometimes our patient population is it'd be difficult to ascertain that when I look at that particular case that I had.
Yeah, and so that's one of the nuances of medicine, right? That's the hard thing that the gray hairs help you with, because you've seen it all for a long period of time. Yeah, is even though this model, I like this model because you're not pushed to race a patient through. Right. You're pushed to do what you're going to do. Yeah. The only difference is you should have countered earlier. So if you had somebody with vomiting and diarrhea, especially if there's any concern, I tell people just to order. You know what I mean? Yeah. Just to do the workup. I don't know if you know, because I don't remember if you saw that patient. We had a guy that very day that came in, and I remember because he looked good. He was cutting jokes, and I forgot, it was something Salvation Army. He vomits every couple months, and I don't know, he had belly pain. Okay. Do you remember seeing it? Were you there? He might have left. Yeah. Anyways, guy looked great. Heart rate was 120. I told the nurses, look, I'm going to make him a sepsis alert. And they said, well, he shouldn't be, because all he's got is a heart rate of 120. But something wasn't right. You know what I mean? And so when I broke it down, I thought, is he going to be a discharge? Well, he could be. Right. But he's tachycardic. He's got belly pain. He's going to get a CT. He's going to get a workup. There's a chance that there's something going on. Yeah. So I went ahead and did my stuff and put my antibiotics in. He came back with a white count of 30,000, and his lactate was 4 point something or other. Right. And his CTs were all negative. It was crazy. Still admitted him to the hospital. Don't know what was wrong with the guy, but it's just putting people in different groups. The only ones you really want to discharge are those ones that you're pretty sure that they're, that it's going to be straightforward. You can get them in and out. So anyways, bring stuff.